Morning, sir. So, good morning again. Dr. Vijayakumar gave me this topic from glucose to glomerulus, Dapa story. So, like all stories, we'll start at the very beginning. Before we proceed, just look at these three molecules. Just mentally label it A, B, and C. And which one, is there a pointer? Am I not seeing the pointer? Oh, yeah. Okay. So, is this glucose? Is this glucose? The main difference between this and this is here the hydroxyl groups are in this carbon 2 and 3. In this, it's in the carbon 3 and 4. Or is this glucose? So just keep it in mind. We'll come back to that. Just to wake everybody up. That's all. I thought, like I said, we'll start at the very beginning and talk about why SGLT2 receptors actually evolved. Very early in evolution, glucose was actually more precious than gold, obviously. Glucose was the molecule that was essential for survival. And interestingly, I just wanted to go and see why did glucose become the molecule of choice? Why did it become the molecule of choice? Why is it the one that is, all our metabolic pathways are geared towards glucose handling as compared to other hexoses like fructose, mannose, and galactose? And glucose has some properties. First of all, it's very stable in solution. It is actually the non-enzymatic glycation rate is the lowest among the hexoses. It's the highest in fructose. And of course, mannose is more of a structural carbohydrate. Galactose is also moderate. So it is the lowest among the hexoses. So non-enzymatic glycation rate is the lowest, and several other factors. So this is the chemistry of it, but this is the reason why glucose became very necessary. And of course, the glucose, the metabolic pathway ensured that we got a high and efficient yield of energy from glucose. So because the primitive life needed to get a lot of glucose into the cell, glucose transporters evolved. Glucose transporters, we all know, are of two types: the facilitated transporters, or GLUT, or the glucose transporters, which just push the glucose into the cell. You need a concentration gradient. It's a passive facilitated diffusion. You don't need ATP. It evolved pretty much soon after life evolved. It is seen in all life forms, including bacteria. So GLUT transporters are present among all forms of life. The sodium glucose linked transporters evolved a bit later. It's mainly found in animals, and it evolved for better nutrient absorption among plant, particularly among animals. So of course, we are all familiar with the type 1 SGLT, which is present in the intestine, and the type 2, which is present in the kidney predominantly. And these are active transporters. It's coupled with the sodium gradient. You need an ATP to push the glucose into the cell. This is our current understanding, and this is just a very basic sort of summary of the glucose transporters. We are aware that GLUT4 is predominantly present in the skeletal muscle and adipose tissue. Liver has GLUT2, pancreas has GLUT2, intestine and kidney have this SGLT1, SGLT1 and 2. Brain has all of it. The glucose sensing by the brain is a very, very complex mechanism. It's got pretty much all of the SGLT receptors and all the GLUT receptors. And this is how the SGLT2 receptor works. From the urine, it reabsorbs the sodium and the glucose using an ATP, using the energy from ATP. So this has to do against a gradient. It has to pull in the glucose from the urine. After that, the sodium enters the blood, again using a sodium-potassium ATPase pump, whereas the glucose just diffusely, passively comes across using the GLUT2 receptor back into the blood. And of course, we know what happens in people with diabetes. Because there is more glucose reabsorption, the blood sugar is high, so there is more glucose which goes out into the urine, and this gets reabsorbed. So the body thinks that glucose is a very precious commodity, and it's trying to reabsorb it. Because it reabsorbs glucose along with sodium because of the presence of the SGLT receptor, there is reduced sodium delivery to the macula densa. So the macula densa thinks that the body is volume depleted. So what it does is it causes vasodilatation of the efferent arterioles and vasoconstriction of the efferent arterioles, so that the blood flow to the glomerulus is preserved. And this is what happens in the diabetic kidney. when you add SGLT2 inhibitors, because you're preventing that reabsorption of glucose, this afferent arteriolar vasodilatation is reset and the constriction occurs. For the efferent arteriolar vasoconstriction is where the ACE inhibitors and ARBs come into play. So this is basically the way by which SGLT2 inhibitors work. I think we are familiar with the concept of how they work by now. Now moving on to the SGLT2 inhibitors itself, I wanted to just go back and look at how they were discovered. We are all familiar with the fact that it was isolated from the apple bark tree. Not that people knew that the apple tree bark was being used for treating diabetes. In fact, that apple tree bark extract was used for treating fevers and malaria. And in 1835, French chemists isolated the chemical called fluorescein. At that time, they didn't know what it was. They just sparked it and they said there is this chemical. Another 50 years later, a German scientist this was a time when the chemists were looking at all of the sort of natural things, and they were studying all of the chemicals present both in plants, plants, the various parts of the plants and the trees. And what this scientist found was that when dogs were injected with fluorescein, their urine output increased and they developed profound glucosuria without high blood sugar. So this was the start. Obviously, that initial fluorescein molecule, because it worked on both the SGLT1 and SGLT2, when you inhibit the absorption of glucose in the intestine, it tends to cause a lot of gas. That undigested glucose, undigested carbohydrate passes down into the lower reaches of the intestine. Both the small intestine, large intestine is broken down by the bacteria, and it causes a lot of gas. So for the next sort of, I would say almost, I think 80, 90 years, nothing much happened with this molecule, though they were aware of its properties. And there was also a concern. Are we doing something wrong if we push out glucose in people with diabetes? Is it going to harm the kidney? Of course, to cut a long story short, after that, these more selective SGLT2 inhibitors were developed. Cana among the three has the most sort of spillover effect on an SGLT1 also. It is not as selective for SGLT2, but both Dapa and EMPA are very selective for the SGLT2 receptor. Now moving on to the other part of the talk, we all know that the prevalence of CKD in people with diabetes is quite high. In fact, this study, which was done looking at the prevalence of CKD around the world, showed that particularly in Asia, people with diabetes, 2/3 of them have CKD. Only 1/3 of them have no CKD. And CKD was defined either as an EGFR of below 60 or a patient with albuminuria. So very high prevalence and very under-recognized and under-diagnosed. Of course, things I think are improving now. We are getting more into the habit of calculating EGFR. We're making sure that we are getting the microalbumin urine ACR ratios done for our patients. The problem that happens in diabetic nephropathy is the initial sort of metabolic dysregulation that occurs because of the hyperglycemia. Of course, it sets up the inflammatory pathway, but because of this changes in the tubuloglomerular feedback, because of the hyperfiltration of glucose, these hemodynamic perturbations also cause, along with the metabolic dysregulation, it causes inflammation. So the macrophages infiltrate, and the macrophages leads to further damage to the kidney and progressive fibrosis. Why this is important to know is because intensive glucose control, once a person with diabetic kidney disease, can maybe potentially slow down the progression of kidney disease, but it will not halt progression. This is because those maladaptive responses with respect to the hemodynamic, with respect to the fibrosis changes, that cannot be reversed once it is set in place. So, like Dr. Bavadarani said in her very brilliant talk, primordial prevention may be necessary. We are talking about primary prevention, but even earlier primordial prevention also, but making sure that we give these molecules early enough. So I'll talk about the data with respect to the kidney. Around the time that Dapa was put into the market, these are the outcomes in the DECLARE-TIMI trial. DECLARE-TIMI was just done to look at the safety of this molecule in people with diabetes with CVD risk factor, so looking at cardiac safety. But what they found was that there was a significant reduction in renal specific outcomes, almost a 50% reduction. And remember, this was in about 8,000 patients with a 4-year median follow-up. So even at the end of 4 years, they found that there was a 50% reduction in progression or development of CKD. 45% of the people in that group had an EGFR of 60 to 90, and only 7% had EGFR of less than 60. So this was the initial data from the DECLARE-TIMI trial. Around this time in 2013, this very interesting study was published in mice. But I thought it just interesting for us to go through the data. These were done in what are called DB mice, which are the diabetic mice, and you can see that the blood sugar levels are very high. When these mice are given Dapa, if you see this green line here, their blood sugars come down very well. That's the green line here. In addition to the reduction in the blood sugar, what they found was that there was also a reduction in the urinary albumin in these mice. As compared to the native mice, there was also a reduction in the urinary albumin along with the reduction in the, blood sugar levels. What they also did in this study was they actually did renal biopsies, and they found that there was a reduction in the deposition of type 4 collagen. So this last one here is the diabetic mice that were given dapagliflozin, and this is the control mice. So you can see that these were the diabetic mice with a lower dose of Dapa, and this is the mice with no Dapa, the second one. So you can see that the thickening and the collagen deposition is much less. Similarly, the mesangial expansion, which is one of the hallmarks of diabetic kidney disease, is significantly reduced in the mice that were given Dapa, almost back to baseline, not completely back to baseline, but almost back to baseline. Mesangial expansion came down, fibrosis reduced. So again, this is the mice that was given the Dapa, and this was the control mice. With a lower dose of Dapa, you didn't see it. With a relatively higher dose of Dapa, you could see that the fibrosis reduced. So this was a proof of concept that giving SGLT2 inhibitors, contrary to initial thoughts that maybe it was going to worsen kidney problems, actually has a extra beneficial effect upon the kidney because it alters those hemodynamic perturbations. Another interesting thing from this study was that there was an improvement in the beta cell mass. So the beta cell mass, which was depleted in the diabetic mice, was restored to normal at the end of 3 months. In fact, above the control mice also. So just another additional interesting fact that I found in the study. And other findings from that same study, several of the pro-inflammatory genes came down, anti-apoptotic factors came down, macrophage infiltration came down. So pretty much everything that you expect because of the hyperglycemia and the changes related to that improved with the Dapa administration to these mice. Around this time, the Dapa heart failure trial also came out, and as expected, even in the Dapa heart failure trial, there was a reduction in the kidney outcomes by about 30% in this trial. Of course, then they went on to set up the Dapa CKD study. What if we use Dapa in people with chronic kidney disease? And this was done in about 4,300 people. These were the inclusion criteria. This was the EGFR that was studied. 2/3 of them had diabetes, 1/3 of them had CKD due to other causes, hypertension, interstitial nephritis, and so on and so forth. So, and they were randomized either to the placebo group or to the Dapa group. And these were the results of the study. At the end of a medium of just 2.5 years of follow-up, a 40% relative risk reduction, a 5.3 absolute risk reduction in preventing the progression of kidney function, so a decline in the EGFR, progression to end-stage kidney disease or death. And I just put up the slide. This is a sub-analysis of the Dapa CKD, just to say that the people who are at the highest risk of progression, so the blue is when they were put on the Dapa, the people at the highest risk of progression had the highest benefits as compared to people who are at lower risk. So we should not be worried about using it. The current recommendation is to use it with an EGFR of above 20. It also reduced the risk of CV death, it reduced all-cause mortality and hospitalization. This is the current recommendation about usage of SGLT2 inhibitors in chronic kidney disease or diabetic kidney disease. You use it with any EGFR 20 to 60, obviously, because if that is the way you're diagnosing your CKD and they have diabetes, you have to put them irrespective of the HbA1c. Similarly, if they have micro or macroalbuminuria, irrespective of the EGFR, irrespective of the HbA1c, you have to put them on a SGLT2 inhibitor. This is the current guidelines. Same with the no diabetes also. And we give it to slow down the CKD progression and to reduce the CVD risk. These are modeling studies. Again, this graph has been shown to say that if you put people on SGLT2 inhibitors, you're preventing the progression to end-stage kidney disease by approximately 11 years. Even when you start with an EGFR of 60, the lower the EGFR that you start with, you still get some benefit, but it's not as pronounced as when you started earlier. Just a couple of practical points about initiating SGLT2 inhibitors in the treatment of CKD. Assess their A1C and medications. Like I said, irrespective of HbA1c, they have to be on it. If their HbA1c is already low, say less than 7, and they're taking insulin or sulfonylurea, consider reducing the insulin or stopping the SU to prevent hypoglycemia. If they're hypovolemic, reduce the diuretic until they are euvolemic to prevent hypovolemia. If they are hypotensive, again, reduce the diuretic or hold other BP medications to prevent hypotension, and initiate at a dose with cardiorenal benefit. So this is also important. We have to continue the ACE inhibitor and ARB. We have to continue blood pressure medications. We have to prioritize ACE inhibitors, ARB, SGLT2. If at all, we consider reducing the diuretic to prevent this hypovolemic effects. If their BP permits it, then you can reinitiate. So coming back to what I started off with, I don't know how many of you got it right, but this molecule here is glucose, where on this, if you number it from this side, the one which has the hydroxyl groups here, this aldehyde group here, so this is glucose. Galactose is very, very similar. And I didn't talk about it today, but galactose uses pretty much the same receptor as glucose. So galactose is obviously what we get in, it's the hexosponge in milk. It's very, very similar. You can see that only this hydroxyl groups have moved up one, but they use the same SGLT2, SGLT1 receptor. And this is fructose, which has what's called this ketone group. And this is the one that is more prone to non-enzymatic glycation. So in my talk, I spoke about why glucose evolved, why glucose became essential, about the evolution of the SGLT2 inhibitors from the bark of the apple tree. Currently, apart from the benefits I spoke about today with the kidney and the heart, we also have data saying that it helps to reduce seizure risk, it benefits sleep apnea, it reduces the risk of NAFLD, it reduces atrial fibrillation, it reduces all-cause mortality, CV mortality, and sudden death. I shall stop here and happy to answer questions later. Thank you.